Yeah.
Thank you to Dr. Muralidhar and IACA for inviting me again here, and thank you to the moderator for kindly introducing me. It's my second year here, and as stated, I work in Papworth Hospital, and that's our new building where we're going to move into. We were supposed to move into last April, but as things stand, it's been delayed, and we'll be moving in sometime next year. So because of time lost, we got a royal charter, and now from Papworth Hospital, we've just become Royal Papworth Hospital. You know, there's a historical precedent to it. Those of you who are aware with Indian history know the first war of Indian independence, or the Sepoy Mutiny for the British, was fought in 1857. And consequent to that, India got a royal charter, and Queen Victoria became the Empress of India. Independence came in 90 years later. Hopefully our move doesn't take that long. Anyway. Moving on, I don't have any disclosures. What I'll be talking about is essentially aortic valve anatomy. We'll be discussing about the evaluation of the aortic valve for the transesophageal route. And I'll be talking very briefly about pathophysiology of aortic valve lesions. So moving on to aortic valve anatomy. So most of you from first year medical school will remember this diagram. So to ensure just a quick reminder, so the heart has got two semilunar valves, two atrioventricular valves, and if you look at the anatomy of the aortic valve, it sits posteriorly to the pulmonary valve. It has three cusps normally, okay, the right coronary, the left coronary, and the non-coronary cusp, and it sits just anterior to the mitral valve, okay. So to understand AV anatomy, so this is a paper that I found out while trawling through the papers, which is quite detailed analysis of the geometry of aortic valve. Should I take you through this paper in totality? No, I won't. I was just joking. Okay. I think you probably need a PhD in advanced calculus to understand that paper, but there we are. What I will talk to you is essentially the clinical aspects of aortic valve anatomy. So aortic valve is a complex. It essentially contains the valve leaflets, the subaortic segment, the annulus, the sinuses, and the sinotubular junction. You cannot evaluate the valve leaflets alone. You've got to evaluate all of this in continuum. Similarly to what we call as the mitral valve apparatus, this is what constitutes the aortic valve apparatus. Okay? So looking at the gross anatomical specimens of the aortic valve, when you open it, you essentially get three parallel lines. The blue line, line 1, shows the position of the sinotubular junction. The line 2 is where the sinus of valsalva sits in, and that forms the area where the arteria meets the ventricle, okay, in between the scallops. And 3 is where the basal attachment of the aortic valve leaflets lie, or what forms as the echocardiographic annulus. If you put the three rings together, what you get is a crown with three rings. It's a corona-like structure. And that's quite important because this is how the architecture of the aortic valve is, and when this gets damaged, you get problems. We need to briefly understand the relations between the aortic valve and the root. The annulus of the aortic valve, the radius of the annulus of the aortic valve is equivalent to half of the free margin's length, and that is mathematically proven the best way to cover a circular orifice with three leaflets. That's why nature's designed the aortic valve into three leaflets and not two normally. And the circumference of the STJ will be equal to the total length of all the three free margins, so that when it opens up, all the three leaflets will oppose against the STJ. And the relation with the aortic cusp and the base of the attachment of the aortic cusp leaflet is always about 1.5 times the length of the free margin. All this is quite important if you're doing aortic valve repair surgeries to sort of ensure that the architecture is, recreated after valve repair. Then we move on to the sinuses of valsalva. So this was described by the Italian Antonio Valsalva. And histologically, this has more collagen at the base of the sinus, and as it progressively moves to the aorta, there's more elastin. The reason why this works physiologically is in end systole, the ST junction is actually wider than the aortic annulus, whereas in end diastole, the aortic annulus is slightly wider than the ST junction. And this is a dynamic phenomenon that happens with every systole and diastole. Okay, and this When it's lost, you have problems with aortic valve patency. What is the role of the sinuses? So why does nature give sinuses of valsalva to us? So the role of the sinuses in diastole is to prevent excessive shear stresses on the aortic valve leaflets. It forms a very nice spherical structure, the sinuses, along with one of the valve leaflets, and reduces the amount of shear strain on the leaflets. And in systole, the sinuses actually create eddy currents between the valve leaflet and the aortic valve wall. So this will prevent the leaflets of abutting against the coronary sinus, though this is not important as much. But what it more importantly does, it pushes the aortic valve to shut quickly in diastole so that early diastolic regurgitation is prevented. So this is what happens normally. And why does it form a sphere? Because a sphere is the minimal surface area you can get for a given volume of pressure. And that's why in nature, most things form a very nice sphere if it has to reduce stress and strain. Okay? So that's why you get the sinuses forming a leaflet. Let's move on to TE evaluation of the aortic valve. Okay. So this is a very interesting paper. It was a very good paper. I recommend you to read it, which details about echo evaluation of aortic valve. And what they describe is primarily the 4 views shown. Mid-esophageal short axis view, mid-esophageal AV long axis view, transgastric long axis, and deep transgastric long axis view. I will sort of take you through what I do to evaluate the aortic valve, okay, apart from what is there in the paper. Of course, we all start off with this view to evaluate the aortic valve, the mid-esophageal AV long axis. The way you develop this view is with the probe in the mid-esophagus. You increase the multiplane angle to about 30 to 45 degrees, and you get a very nice Mercedes-Benz view, as it is called. So the picture on the left is a normal-looking aortic valve. The picture on the right is where the aortic valve is not opening. Any reasons why? The patient's on some kind of mechanical cardiovascular support. Okay, so that's one. And if you see the 3 leaflets, so the leaflet that's closest to your probe is usually the non-coronary. The leaflet in association with the right ventricle is usually the right coronary, and the leaflet which is left is the non-coronary, sorry, the left coronary leaflet. Okay, so from this particular view, what I normally tend to do is withdraw the probe slightly. Okay, so the picture on the first left shows an aortic root abscess, then you're seeing a dissection flap in between, and the picture on the bottom right is when you see, when the probe is withdrawn slightly, you get to see the left main stem. Okay, and if you use a 3D probe, you cross-plane at that level, you get to see, the proximal regions of the aorta as well. So that's quite beneficial to use the X-plane quite extensively when you're evaluating the aortic valve. Okay, and the gross anatomy specimen is one of a rheumatic valve where you're seeing leaflet tip calcification as such. Okay. Then moving on to the next view is the mid-esophageal long axis view for evaluation of the aortic valve. You develop this view from the short axis view by adding 90 to whatever multiplane angle you've got the short axis view at. Okay. And what you essentially will see is the left ventricle, the LVOT, and you get to see 2 aortic valve leaflets. The valve leaflet associated with the right ventricle is the right coronary cusp. The other one could be the left or the non. Now, how do you determine it is the left or a non? Is what you do is you put in a multiplane angle, an X-plane at the level, and you will be able to make out what leaflet is what quite clearly. And you also use color flow Doppler at this level to ensure that there's no regurgitation. Okay. Moving on to a mid-esophageal aortic valve in the long axis. So this view is developed by zooming in on the aortic valve from the long axis view. Okay, and this view is very good to measure the vena contracta in case of aortic regurgitation, and also you get to measure the PISA in case there is aortic regurgitation. Okay, and the measurements that you are expected to make, the aortic measurements, are the LVOT, which is measured about 1 centimeter into the LVOT from the aortic annulus. The aortic annulus is measured at the tip of the attachment of the leaflets to the aorta. The sinus of valsalva at its widest, the STJ, which is obvious, and the centimeter distal to the STJ is where you measure the diameter of the ascending aorta. And you also try and measure the coaptation length of the AV, which should normally be about 3 to 5 millimeters. Okay, and then I would use an M mode, initially without color to see if the leaflet movement is adequate. And then I would use an M mode with color flow Doppler to assess the severity of aortic regurgitation if there is any. Okay? Then I would move into the transgastric AV long axis view. So the view is developed by advancing the probe a bit further from the mid-sphagial view and increasing the multiplane angle to about 120 degrees. This view is important because it helps you to line up the continuous wave Doppler and the pulse wave Doppler along the LVOT and the aorta. So it helps you to measure gradients. Okay? So by far, this is where I would stop normally, but occasionally I go into the deep transgastric long axis view. Okay? This view has given me a lot of anxiety. 2 of my patients' blood came from this view, so I don't tend to use this view unless absolutely needed. So what this view does is facilitates you to apply pulse wave and continuous wave Doppler along the LVOT and aorta to help you measure gradients and assess severity of regurgitation. Okay? Some of the other views that might help you is the mid-esophageal 5-chamber view, okay, which gives you a good relationship between what the mitral valve, LVOT, and aortic valve is doing. Okay? But the information gained from this view can be gained from the AV long axis view as well. So this view is not mandatory for evaluation of the aortic valve. Okay? What do we measure once we get the pictures? Okay, you could measure planimetry, but of the aortic valve opening. It's very, very unreliable. You don't know if you're cutting the valve appropriately, and you don't know if you're drawing the circle appropriately as well. So I wouldn't recommend it. The best way to measure aortic valve area is the continuity method, and the formula is stated on the screen below. So essentially, you measure the LVOT diameter, you measure the LVOT VTI in the double envelope, and you measure the aortic valve VTI that is shown on the screen, and you apply them in that formula given there, and you should be able to get the aortic valve area. Okay? It's quite commonly used everywhere. And measures for quantifying AR. The other thing that you need to measure is the effective regurgitant orifice area. So this is developed from your PISA, where the formula is 2 pi, R is the radius of the PISA that you get, and VA is aliasing velocity, okay, divided by the peak velocity of the AR jet. And you do measure the pressure half time, again, which is as shown in the picture, where you measure the time taken for the pressure to reduce by half at the aortic regurgitant velocity. These are the normal dimensions, okay. You need to have some kind of reference if people are taking exams. What I normally remember is 13, 19, and 15. So just 3 numbers to remember. That's how I go, because most of my echo machines are set up for indexing to body surface area normally when we use them, and it helps us that way. Okay. Moving on to pathophysiology of aortic valve lesions very briefly. So aortic stenosis, it's one of the most common valvular lesions I see in my practice. It could be acquired or congenital. Degenerative is one of the most commonest causes of acquired valvular aortic stenosis. Okay, I don't see that much rheumatic in my practice, but apparently in India there is a lot more rheumatic diseases around. Okay, and you get congenital, which could be in your bicuspid valves. The difference essentially between degenerative calcification and rheumatic calcification is area of calcification. In degenerative calcification, the aortic valve begins from the base of the leaflet. So the leaflet remains functional for a lot longer. Whereas in rheumatic calcification, the leaflet begins calcifying at its tips. So you begin to get symptoms a lot quicker. Okay? And we all know about Laplace's law. So the wall tension is a factor of pressure, radius, and wall thickness. And the ventricle always tries to reduce wall tension. The way you reduce wall tension is by decreasing the radius and increasing the wall thickness. And this is what happens when people exercise. Okay? The muscles become big to reduce the tension on them when they're exercised. And similarly, when the ventricle is faced with a stenotic aortic valve, it hypertrophies as well. So its radius decreases and the wall thickness increases. Okay? And this needs to be seen every time you evaluate the aortic valve by also evaluating the left ventricle. No aortic valve evaluation is complete without evaluating how thick the LV is or how dilated the LV is. Okay? Brief note about aortic stenotic pathophysiology. So everybody knows this pressure volume curve. So the bottom right, you get the end diastolic volume, then you get the phase of isovolumetric contraction, then the phase of ejection, and then you get the phase of isovolumetric relaxation. So the dotted curve is the normal, and the bold curve is what aortic stenosis does to the ventricle. So essentially, you get elevated end diastolic pressures, you get elevated systolic pressures, and you get a preserved stroke volume. Okay? And if you plot elevated end diastolic pressures, you get the Frank-Starling curve, which we are all aware of. Okay? And LV hypertrophy happens, as discussed. Because of a stenotic valve, you get fixed cardiac output, which causes syncope. You get a stiff LV, and that causes breathlessness. The coronary flow reserve is reduced, but the demand of the oxygen because of hypertrophied ventricle is increased. So patients with aortic stenosis get angina. Okay? Talking about aortic regurgitation's pathophysiology, so L. Curie gave us this wonderful classification of aortic valve regurgitation. So he divided it into 3 types. Type 1 is with normal aortic valve leaflets. Type 2 is with prolapsing aortic valve leaflets. Type 3 is with restricted aortic valve leaflets. In type 1A, what he said was the whole of the aortic ascending aorta and STJ and root, everything dilates or becomes aneurysmal. So you get regurgitation. In type 1B, it's mainly the STJ that dilates and causes regurgitation. And type 1C, you get the sinuses dilating, causing regurgitation. And 1D is when there's a perforation in the aortic valve, which causes regurgitation. This is quite important surgically because the repair techniques differ according to the type of regurgitation caused. Okay? And it's important for us to know what to advise the surgical team as to what we think it is and help in the diagnosis and management of this lesion in theater. Etiology, as we say, could be due to dilated aortic root, could be due to damaged leaflets. Okay? And severity of aortic regurgitation is dependent on the regurgitant orifice area, the diastolic pressure gradient, and the length of diastole. And I'm just concluding, aortic regurgitation severity, as in the acute phase, as you can see with the bold curves, you get to see fairly fixed stroke volume, but really elevated end diastolic pressures. In chronic, you get very big stroke volumes, but the end diastolic pressures don't get elevated that much. There is always a volume overload, and the LV usually gets grossly dilated, and diastolic perfusion is affected because there is no severe diastolic runoff. That concludes my talk. Thanks a lot.